Good day, everyone. My name is Yamini Oseguera Bhatnagar with HIVE. I'm the Power Health Coordinator. I'm here live in San Francisco broadcasting, and I'm joined by colleagues from many, many places to talk about safer conception, supporting HIV-affected individuals and families in their reproductive goals. Just a little bit about HIVE. We are formerly Bay Area Perinatal AIDS Associates, AIDS Center, and now we're HIVE, a hub of positive reproductive and sexual health. Also GlobalSHARE, which is the beginning of a global movement, translating emerging science into action and supporting every person's reproductive goals. We are a global community of women and men living and affected by HIV, researchers, clinicians, policymakers, health workers, advocates, founders, and other stakeholders committed to empowering HIV-affected individuals and couples in accessing their desired reproductive and sexual choices. What I'd like to do is to open it up for our panelists to introduce themselves, and maybe we'll start with Miss Angela.
Oh, thanks, Yamini. Hi, everybody. My name is Angela Kaida. I am an assistant professor in Canada Research Chair in the Faculty of Health Sciences at Simon Fraser University, and my work and interest and passion is all related to sexual and reproductive health and rights of women and people affected by HIV. And it's so lovely to be here. Thank you.
Thank you. Lynn, could we have you introduce yourself?
Sure. Hi, everyone. My name is Lynn Mathews. I'm based in Boston at Massachusetts General Hospital and Harvard Medical School, where I'm in the infectious disease division and also at the Center for Global Health. And my work is mostly around research for developing and implementing safer conception programs in Uganda and South Africa. And I'm so excited to be a part of this, and so thrilled that HIVE and GlobalSHARE are kind of getting this work out into the world and out of just our journals.
Yes, this is very exciting and groundbreaking also. Natasha, will you introduce yourself?
Hi, I'm Natasha. I work in Johannesburg in South Africa. I'm an HIV clinician who has been interested in safer conception for a couple of years and started a clinic providing the service 6 months ago.
Great. You are definitely doing the work on the ground, and we'll hear more about it in a few minutes. Thank you. Shannon.
I'm Shannon Weber, and I'm the director of HIVE. I work with Yamini in San Francisco. This just really thrills me to have all of us together because we've been connected and sometimes in meetings, but often it's been over phone calls and emails, and it's really beautiful to start to create this community of people who are committed to moving forward the rights of people affected by HIV to have a child. So we've been offering PrEP at our clinic in San Francisco since 2010. And also interesting about our program is in 2012 we started an initiative for men called ProMen, Positive Reproductive Outcomes for HIV-positive Men. And this is when we started to look about how men were being supported in their decision making about whether or not to have a child, and we'll talk more about that later. Thank you.
Thanks, Shannon. Love working with you.
Ditto.
Sheila, will you introduce yourself?
Hello all, it's good to be here. My name is Sheila Shiwani. I am a HIV doctor, a clinician working with the University of Nairobi, partners in advanced care and treatment. I work in the discordant couple clinics, and recently we began a preconception clinic that's offering safer conception services for HIV-affected couples desiring children. I'm glad to be part of GlobalSHARE as we roll out this initiative globally. Thank you.
Thank you. We're so happy to have you. Angela, Lynn, Natasha, Shannon, Sheila, you are a fierce group of women, and I'm very excited to do this work with you. Let's take the conversation into talking about why this is even important. Safer conception, why is this a thing? Who needs safer conception services and programs, and why? Give us sort of the breakdown, Angela.
Oh, great. Okay, well, thank you, Yamini, and thanks, Shannon, for your leadership on getting us all together. So I'm really grateful for the opportunity today to talk to this community about the importance of safer conception programming, as well as a need to really think about and ground our work in a sexual and reproductive rights framework. And so I'll just sort of speak to the issue from that perspective. Now, I'm curious and interested to see the discussion that we can have throughout the course of the panelists. So, of course, to start with, HIV-affected individuals and couples face a dilemma when attempting pregnancy. They have to balance the risk of HIV transmission with the desire for a child. But across the globe, people living with and affected with HIV continue to express desires for parenthood, for motherhood, for fatherhood. And a substantial proportion actually do risk HIV transmission or acquisition to achieve their pregnancy goals. And so we have this really desperate need to provide services that do support desired pregnancy while minimizing risks to maternal, partner, and infant health. And so we use the term safer conception here to encompass, I think, what we really understand to be a person-centered approach to supporting pregnancy attempts and pregnancy desire through provision of access to a range of biobehavioral strategies which support pregnancy while minimizing HIV transmission risk. So to me, safer conception is not just about particular methods. It's about an approach, and it's a framework that really puts the person at the center of the work that we're doing. And so we now know very well that people living with HIV who have access to antiretroviral therapy can live long and very healthy lives. And we also have this really exciting growing evidence about how optimal use of antiretroviral treatment is also associated with a dramatically decreased risk of HIV transmission, right? A transmission risk approaching zero in optimal conditions. Coupled with access to pre-exposure prophylaxis, or PrEP, and use by the uninfected individual, and again, the dramatically reduced risks of acquiring HIV. So we have a context where advances in science and in clinical and public health are really changing the reproductive landscape for people living with and affected by HIV. And so this altered landscape is also furthering and pushing a global rights-based discourse. It's really changing how we talk about sexual and reproductive rights and how we operationalize those rights in our programming. And just earlier this year, I'm sure many of you have already seen that the Journal of the International AIDS Society just published a full supplement dedicated entirely to advancing sexual and reproductive health and rights and really furthering that conversation. So, this conversation is long, and it's been winding, and it takes spins and turns. But the first statements on reproductive rights really emerged for people emerged in 1994 at the ICPD conferences, where it was put forward that all people have the right to have children freely. The decision to have children freely, if and when and the number of children that they desire, with the support, services, care, means to do so safely. And so this definition of reproductive rights translates, of course, to include all HIV-infected and affected individuals. And so when we think about the community of people who are deserving of access to safer conception programming, that includes women living with HIV who have partners of unknown or known HIV status. It includes same-sex individuals affected by HIV. It includes HIV uninfected women who face a high risk of HIV acquisition. So the community is not just people who are known HIV serodiscordant heterosexual couples. It's a bigger community than that. And part of, I think, the sexual and reproductive rights language helps to extend our vision and our view of what safer conception can offer and the community that it can serve. But there are several sort of key barriers to sexual and reproductive health and rights, and these really include the intersecting forces of gender inequity, stigma and discrimination, violence, growing threats of HIV-related criminalization. And these factors are intersecting, right? And they're working in concert to compromise timely access to medical, public health, social services, and compromising these good health outcomes that we know basic science and clinical science and trials show us are possible. So within the conversations and the work that we're pushing in safer conception programming, we really need to confront these rights violations head on. And they're operating, I'd say, at multiple levels. And I'll just give an example, and I don't mean to pick on providers in the least. It's just some of the recent qualitative work coming out among providers really suggests that providers, this is work primarily in Uganda that I'm familiar with, but really suggests that providers are largely empathetic. The foundations of safer conception programming, of risk reduction, and people living with HIV expressing fertility desires and intentions, there's a lot of empathy from providers understanding that sociocultural need and individual desire for pregnancy. But the operationalizing of those rights, or understanding reproductive rights, into individual level clinical care counseling is very challenging. It's very fraught with difficulty. And we see a very acute tension, I'd say, between a rights-based discourse and practice, okay? And the ways in which practice the messaging about pregnancy in the context of HIV can still remain largely discouraging, right, and avoiding HIV transmission risk at any cost. And so that piece of the puzzle where our rights-based discourse and language is not matching with our practice becomes, I think, a really critical area for discussion and a challenge for how we implement and how we roll out safer conception programming and discussions. And certainly that reality of a disconnect between rights and practice is not limited by any stretch of imagination to the Ugandan setting. And really there's a lot of evidence to suggest that globally this is an area that we are going to have to work on. And part of working on that is having these kinds of discussions, I feel, and the opportunities to have these kinds of discussions. And so one last point I would just like to put forward in our discussion of safer conception programming and rights relates to the fact that I think we are increasingly talking about or becoming a little bit more comfortable with reproductive rights in our safer conception work, but we have a real need to push forward on recognizing sexual rights and talk more about that and the rights that exist for a safe and satisfying sexual life for all of us, including people living with and affected by HIV. And so we currently talk about sexual activity with such a risk reduction framework, and we really deny and sort of mute some of the really important conversations that we need to have about forced HIV disclosure, or the violence that still accompanies so many women in particular who disclose HIV status, the stigma, the discrimination, and of course increasingly criminalization. And these factors are the very factors that if we are not upfront about are certainly going to reduce clients' of willingness and ability to connect in with the services and programming that we hope to design, implement, and put forward. And so I'll just close my statements by saying that I think that in order to, I'm really excited about this time and the conversation that's happening about supporting pregnancy among HIV-affected people. And I think that part of a rights-based orientation to our approach needs to start with privileging the voices and realities of people living with and affected by HIV, and making sure that within that we're very mindful of the ways that gender inequity are going to be further fueled by what we do or mitigated by what we do, hopefully, to some extent. And I think that through this work we can, I'm really, I guess, energized by the opportunity that we have in front of us to change the narrative of HIV and pregnancy from one that's really been very focused on risk and individual risk to one that I think really reframes this conversation that says that people living with and affected by HIV are deserving of both intimate relationships and parenthood. And I think I'm personally very energized by that sort of emerging vision of what safer conception programming can put forward. So on that note, thank you.
Angela, thank you so much. That was energizing, to say the least. And thank you for rooting us in what this is really about, and this reproductive rights sort of framework that we should all sort of begin in this work from. And also thank you for pushing us in the direction of having this sexual rights conversation. And thank you for saying operationalizing reproductive rights in clinical care. And I hope and I feel that we will continue to talk about this. Next, let's move on to talking about sort of specific ways in which treatment and pre-exposure prophylaxis can have and can assist in the conversation around safer conception, and be helpful and effective tools for HIV-affected couples, families, and individuals. And maybe some discussion around the Partners PrEP trial. Lynn, will you talk to us more about that?
Sure, I'm happy to. Thank you, Angela, for, again, framing this all for us in a nice way. So I think that I wanted to share a slide with you guys that I like to use to think about the different kinds of methods that are available for kind of reducing transmission around conception, or basically just reducing sexual transmission while allowing for conception. So ways to reduce transmission without using condoms. And I can't show that to you because our screen sharing thing isn't working, but I'll just sort of, I think of these as kind of Venn diagrams, because there are certain strategies that work best for male infected couples, and there are certain strategies that work for female infected couples, and then there are strategies that work regardless of the partnership. So for male infected couples, something like sperm washing plus assisted reproduction is a great way to reduce the risk of transmission to a woman and allow for her pregnancy. If the woman is infected and her male partner is not infected, something like manual insemination as well as male medical circumcision reduce the risk of female to male transmission. And then kind of in the intersecting areas of the Venn diagram where we have things that work regardless of who's infected is treatment for the infected partner, pre-exposure prophylaxis for the uninfected partner, limiting sex without condoms to peak fertility, to periods of peak fertility, and treating STIs. I love that we are moving towards really being able to focus more on the things in the Venn diagram of overlap, being able to focus on strategies that work regardless of who's infected, because what we have found in our qualitative work, and you probably didn't need qualitative work to know this would happen, but people are really confused. They're like, oh, well, I'm an infected woman, and so I need to go get sperm washing to get pregnant. Well, that actually doesn't make any sense, and that's complicated. Or an infected woman with an uninfected male partner, they might think that the best strategy, a couple where the male is infected might think that manual insemination is a great strategy because there's less exposure, but actually that doesn't make sense. And so I love that as we moved, as treatment is prevention and pre-exposure prophylaxis, as we have more data telling us just how much that reduces the risk, we can focus on strategies that work for everybody and also are not necessarily specific to this whole safer conception question, which I think is helpful in terms of kind of moving safer conception forward. So I'll talk about, I do think it's important to keep lots of tools available to people so people have choice, but treatment is prevention and PrEP, there's starting to be kind of a lot of global support for moving those interventions forward. There's a lot of funding to implement those things. There's a lot of pressure on governments to try to figure out how to implement these programs. And I can't say the same for sperm washing, manual insemination. And so it's nice to have strategies that are kind of part of the global prevention strategies that work for safer conception. So in terms of what we know about treatment as prevention, so antiretroviral therapy for the infected partner, so the HPTN 052 trial showed a 96% reduction in the risk of transition to an uninfected partner if the infected partner is on treatment. That was a big clinical trial, so the infected people who were taking treatment had really good follow-up and their viral loads were monitored much more frequently than is really feasible in most settings, but they did have great viral suppression, and the risk of transmission was 96%. And actually, when they did deeper analysis, the only transmission events happened in partnerships where the infected person hadn't actually been on treatment for very long. So there was actually no transmission among people who had been on treatment for at least, I think, 8 weeks when they did the genetically linked transmission. So, you know, some people look at that data and say there is no risk of transmission if the infected partner is on treatment with a suppressed viral load. We also, in the past couple of years, have had increasing data that really proves that in addition to treatment being a great prevention strategy, it's also really good for the infected person. So we now have great data showing that if you're on if you have HIV and you're on treatment, your life expectancy may actually exceed that of people who don't have HIV, probably because you get better clinical care or you're engaged in care. We have data that people who initiate treatment as soon as they're diagnosed have lower mortality than people who wait to start until their CD4 count declines. So there's a ton of energy and enthusiasm around trying to initiate lots and lots of people on treatment. I think that's great for safer conception, because if you were working with a discordant couple and they want to have a kid, if the infected partner is on treatment, that's great for that person's health, and it's great for the uninfected partner, and it's great for the health of the future baby. And it's also made it a little bit easier for programs, because now the recommendation is if someone has HIV, they should be on treatment. So you don't have to wait for them to get pregnant, or you don't have to wait for them to get sick, or wait for their CD4 count to drop. Outstanding questions, like things we don't know. So there's a fair amount of data that people who have a suppressed plasma viral load may still have some genital secretion of HIV. And that data has always been a bit puzzling, and people have wondered, what does that mean? And there haven't been a lot of studies that show that if you have a suppressed plasma viral load, but you do have virus in your genital secretions, what is the risk of transmission? I think kind of the population level data from lots of these studies that are implementing ART will help us understand how much we need to worry about that. But I think in counseling people who are worried, that is something that we need to share, that there are some, you know, the treatment reduces the risk by so much, but it's probably not zero in all cases. Also, we know that lots of people have a lot of trouble adhering to medication, and there are a lot of studies going on now to understand, for people who are initiating therapy when they're healthier, might they be less motivated to adhere to therapy a long time? People are going to be now on therapy maybe ostensibly much longer. Is that going to be a challenge? So I think understanding how people will adhere to longer-term ART is an outstanding question. And a good reason to keep lots of options open for people for prevention. It's not, I don't think it's going to just be about treatment. We also know that lots of people don't want to be on treatment. They refuse treatment. They want to wait till they're sick. Until a couple of months ago, lots of doctors and lots of clinics around the world were saying, no, you don't need treatment yet. You're not sick. Now we're going to say, oh, no, now you're sick. You need treatment. That's going to be hard for some people. They might not want to be on treatment. So, and then I think just how we're going to support the effort to get everyone on treatment is a huge question. The current estimates that we have about 15 million people on treatment around the world. The gap is about 22 million people. That's a big gap. So what does this mean for HIV-affected individual and people who want to have a kid? I think it's great news if you know your partner's infected and you want to have a kid with that partner and you don't have HIV. If your partner's on treatment and adherent and has a suppressed viral load, the risk of transmission is really quite low. If you're in a setting where they don't check viral load, which is many settings, probably if they've been on an effective regimen for 3 to 6 months, then they're probably suppressed. Newer and better antiretroviral regimens make people suppress faster, and also the barrier to resistance with suboptimal adherence is getting higher and higher. So that's really good. I think that the treatment as prevention messaging, though, is still tricky, because all of the guidelines, all of the trials also offer treatment in the context of a comprehensive prevention package that includes condoms. So there's still this big issue with providers, policy people feeling comfortable ever saying, like, yeah, you could, not use a condom, it's fine. People are not comfortable with that at all. The Swiss statement a couple of years ago, even before the HPTN 052 data, very strongly said, if someone's on treatment with a suppressed viral load, like, they can forget about the condom because they don't need it. That's extra. Providers are still really uncomfortable with that. And that is obviously something that we have to work on to communicate to people that it's okay to have a kid. In terms of the PrEP data, I think you guys wanted me to specifically talk about the partners PrEP data because that's the PrEP trial, efficacy trial that looked specifically at serodiscordant couples. So they enrolled almost 5,000 couples who were mutually disclosed serodiscordant couples. In Uganda and Kenya, people were randomized to either, and the infected partner was not yet on treatment, uninfected partners were randomized to placebo, tenofovir, or tenofovir FTC, and they showed a reduction in transmission by around 70% between the two arms. And then when they looked even closer at people who were really adherent to the drug, people who were taking the medicine regularly, their risk reduction was about 90%. And so that's a tremendous prevention benefit. And really, that study, as well as a few other studies, really moved the conversation forward to approval of PrEP and now WHO recommendations for PrEP for anybody at substantial risk of HIV, which is not just specific populations, but anybody. Their data was also really helpful in this conversation about safer conception because they had a high pregnancy incidence. So we were able to look at adherence to drug in the context of the peri-conception period, kind of in the 3 months prior to when people got pregnant. I think because of the counseling messages that tenofovir-based drugs might be harmful to the baby, we were worried that adherence might be lower, but actually adherence was really good throughout the trial, including in people who became pregnant. People were not supposed to be in the trial if they were planning a pregnancy, but qualitative data conducted with people who had pregnancy showed that actually most of the people in the study who got pregnant were excited about that. And so they were adhering to the drug, they took it, that was fine. They also were able, in a study that Nellie Mugo published in 2014, they were able to look at among the, I actually have a note here for myself to look at these numbers because I don't remember it. They had about 430 pregnancies in the uninfected women in that study, and they were able to look at 3 years of follow-up at what happened with those kids. So the women had an average of about 5 weeks of exposure to study drug, and they showed that there was no difference in renal problems with the kids or in bone problems with the kids or in length or head circumference. It did look like there was a difference in the pregnancy rates or pregnancy loss rates. So in the women who were in the combined tenofovir FTC study, about arm 43% versus 32% in placebo had an early pregnancy loss, but it wasn't statistically significant. So that's also very helpful data as we counsel people about what we know about tenofovir-based PrEP and pregnancy. I think this other safety questions around PrEP, because there's now been 11 studies looking at PrEP use. We're getting a lot of safety data. It looks like in terms of the kidney possible side effects or toxicities on renal function are limited. So there are definitely statistically significant decreases in creatinine clearance or increases in creatinine that resolve over time. And are not clinically significant. Ditto for bone density studies. There have been a couple of studies now showing that people on PrEP for a number of months will have a decrease in their bone density, but what that means clinically is unclear because it's a statistically significant difference. There are questions about, is this safe for the baby? I mentioned kind of the partners PrEP data we have about early exposure to the baby. In terms of longer-term exposure to the baby, the only data we have of women only getting tenofovir comes from hepatitis B studies, where tenofovir is given to treat the hepatitis B. In those studies, it's real small numbers, but the babies are fine. We have tons of data from HIV-infected women getting tenofovir-based products as their antiretroviral therapy, which don't show any increase in congenital anomalies. And then in terms of other reproductive health considerations, it does not appear, again, from a partners PrEP sub-study that PrEP affects the effectiveness of hormonal contraception. So I think that what's really exciting about PrEP in this context is it's the only tool, really, that the uninfected partner can control. You have to take it for it to work. And I think that a lot of the data that we've seen from follow-up studies of the randomized control trials where women had a hard time taking the drug suggests that if they know it works, it may work better, and that's been now proven in demonstration projects, where in demonstration projects people have actually been very adherent to the medications. I think if people are using this around the time of trying to get pregnant, that's a pretty time-limited period with kind of a clear goal. So it's not kind of this ambiguous taking a pill for the rest of your sexually active life, which hopefully is a really long time. It's a little bit more focused. And I think it just gives people choice. If someone knows their partner's on treatment but they're not sure about how well they're adhering, PrEP is a really good option. A couple of modeling studies have suggested that adding PrEP to treatment in the context of safer conception may not be cost effective. But I think those modeling studies all assume that the infected partner is on treatment with a suppressed viral load, which is not always guaranteed. So I think data to watch out for that will give us more information about how PrEP and treatment as prevention are going to work in the context of safer conception and in general. There's a lot of community treatment as prevention projects that are going on. Renee, Heffron, who couldn't make this call, and Jared Baton are leading the Partners PrEP demonstration project, within which there is a safer conception component looking at implementation of treatment as prevention and PrEP in the context of fertility desires. Glenn Wagner with Jolie Baeza Kashesha and Rhoda Wanyenze in Uganda have some implementation projects going on looking at safer conception. Natasha and Sherry are both leading implementation studies of safer conception services in Johannesburg. Meg Sullivan here in the US is leading a multi-site study looking at PrEP for conception, mostly focused on adherence questions. And Okioma Mameje has a project in Kenya looking at vaginal insemination. And my colleagues and I in Durban are doing some work that's really focused on safer conception programming geared towards men who want to have a kid with an uninfected partner. So there's a lot of exciting data happening, or projects happening in this field, trying to figure out how do we apply the lessons learned about treatment as prevention and PrEP to safer conception questions. And I think it's exciting. I think it's really nice to have tools for safer conception that fall into the bigger bucket of HIV prevention because of the funding, because of the programmatic support. And I also think it kind of, in so many places, it's still very stigmatizing for people living with HIV to have kids, and we really want to work to change that, but it's not going to change overnight. And I think it's really nice to have strategies that work for prevention regardless of your childbearing goals. So I'll stop talking. Thank you.
Lynn, thank you so much. That was that was amazing. You took us sort of to the horizon and gave us an overview of all things sort of scientific about this. Thank you for talking to us about treatment as prevention and sort of the complications around that as well, and about adherence. And we hope to hear more as these population level studies are sort of done as to what's next. Mm-hmm. Thank you for talking about PrEP and the newer biomedical interventions, and thank you for bringing it all together, that there is a need for many different options for prevention as well as for safer conception. Let's move on. I just want to say really quickly to everyone that's watching live, there is a Q&A section. You'll need to log into Google Plus to ask questions. Just type your questions in and we'll go ahead and answer a few of them at the end of this broadcast. And whatever's not answered will be answered in the YouTube comment section at a later time, so you can go back and look at it. Let's move on to Shannon Weber. Shannon, tell us a little bit specifically around sort of lower tech options around actual sort of safer conception. Tell us a little bit about what people can do in their daily lives and at home.
Great. I want to also echo what's been said, but just acknowledge like the real pioneering work of Angela and Lynn. You know, when I was hearing Lynn first talk, those probably first 3 minutes, there are millions of people around the world that if they could hear those first 3-minute talk, they would like breathe again, you know? And we have a video from Lynn on the HIVE website. We also have a video from Angela talking about this reproductive justice framework. It's just really important and powerful to see people coming forward and telling the truth about how treatment works and the value of having a female-controlled prevention method like PrEP. So that's just super important. As Lynn said, at a population level outside of safer conception, these are two really important pieces that we need to move forward. But let's talk about, if we're going to talk about from a rights-based perspective, really we want to offer people choice and options. This is a lesson learned from family planning, that the more options that are made available, the more likely someone is to opt in. And so I see this with couples all the time, because healthcare is not uniformly offered. It's not offered in the same way across the U.S. either. So we can have some of these same challenging conversations in the U.S. that are had in Africa. And so it's really about sitting down with a couple and telling them all the options that are available and seeing what feels comfortable to them. So I am going to talk about some lower technology options, but I do want to mention that, again, from a rights-based perspective, we need to continue to advocate for assisted reproductive technologies to be made widely available. These technologies need not be expensive and need not be exclusive. The reason that it's so important for us to continue to advocate for this is that people living with HIV are affected by fertility issues, sometimes at a higher level. And so you may not be able to get pregnant by having sex. And so we need that available. Also, this next frontier is about us advocating for single parent by choice, co-parenting, and same-sex couples who are affected by HIV who need to have assisted reproductive technologies available. So it's time now, as we have this momentum, to continue to push forward and really demand that that's available so that it can be available to everyone. What are assisted reproductive technologies? Because if you Google and look this up, you're going to see these terms. You're going to see this term called sperm washing, and intrauterine insemination, and in vitro fertilization. So sperm washing is a technique that is done for everyone who accesses assisted reproductive technologies regardless of their HIV status. A lot of people will get confused and think, oh, that's just a special thing that's done for the semen of men who are infected by HIV. But in reality, this is a process that's done thousands and millions of times over. Again, doesn't need to cost so much money. We can make it available because we're doing it all the time. And it's a process by which the sperm is washed, so to speak, in a centrifuge, and then they're just scooping out the most viable sperm and using those either through intrauterine insemination, which we have great videos on our website explaining all this with the proper language, but basically tube up inside the vagina, put those babies up there, those sperm, see if you get pregnant, or in vitro fertilization, in which the washed sperms, and so it's really the most viable sperm, are taken and introduced to an egg, see that they fertilize and put back inside the woman. So that's that. Again, more on the website. But what are some other options? So if we think about, okay, you want to get pregnant. How do you get pregnant? You need to get the sperm and the egg together. Most people are doing this by having sex. And if you want to limit the exposure to HIV, so this would be in the case of where people are using condoms most of the time or all of the time, or trying to use condoms all the time, there's this option which you can try at home called timed intercourse. That's kind of the fancy word for it. It's limiting the time you have sex without a condom to the days in which you're most fertile. And this can be done in the U.S. We talk about it a lot through using a fertility or an ovulation prediction kit. We have a video on our website really talking about how to use the ovulation predictor kit. And I would love to make a video one day with someone who understands how to predict your ovulation by checking the discharge in your vagina, so looking at how thick the mucus is. So there's even lower technology ways of figuring this out. And there's 3 or 4 days in which we as women are most fertile. And so we want to learn our bodies, figure that out. You could chart it on a calendar. You could do this on an app. There's several apps out there that help you chart your fertility as well. And then you're going to have sex on the days in which you're most fertile. And so this would be, obviously, if you want to get pregnant, doing it without a condom. Other ways that you can limit the risk of acquiring HIV that are kind of lower technology is getting screened and treated for sexually transmitted infections. So either partner having a sexually transmitted infection increases the chance of passing on HIV, right? And so this is something most folks can access, is getting screened and treated for STIs. And another option that we don't think about so much but is also PrEP. And so this would be, if you aren't able to access PrEP, maybe you can access PrEP. You could think about, that's post-exposure prophylaxis, using HIV medication after the exposure. It's not recommended that you do this ongoing, then it's recommended that you're on PrEP, but PrEP might be an option. And finally, I believe Lynn referred to this manual insemination. We call it home insemination. We have a brochure on our website in English and Spanish about this. This is in the setting where the woman is living with HIV and the man is not. And it's a simple process that you can have the man ejaculate into a non-spermicide condom and then use a needleless syringe to put the semen inside the woman. And there's every chance that the woman gets pregnant as if you were having sex, and absolutely no contact. So you've eliminated the risk of HIV transmission. Happy for people to contact us on HIVE if they have more questions about how those different options work and how they can access them wherever they're living.
Great. Thank you so much, Shannon. Thank you for telling us what can be done at home. Thank you for bringing up PEP. I don't think that I had thought about that as an option ever at all. And let's move on. Again, Shannon, thank you for reminding us. A lot of resources are on the HIVE website. That's HIVEonline.org. And at the end of this broadcast, there will be a little slide that will be clickable eventually, and it'll take you right to the website and to some of these resources. Let's move on to talking specifically about how this work is rolling out. Let's go to Sheila. Sheila, tell us a little bit about how this work is being done where you are in Nairobi.
For us, the uptake of safer conception services is actually something new. This is something we're trying to actually introduce as part of the HIV continuum of care. For us as a clinic, we found that most of the couples and most of the couples we're seeing are heterosexual discordant couples were coming to us and were expressing fertility desire. And most of them were coming from centers whereby they had actually asked, but probably due to knowledge gap on prevention intervention by clinicians and other factors, probably like very limited wait time when the clinician has the patient to discuss fertility, to discuss conception options. So we saw there was a need, there was an unmet need to discuss conception services with some of these couples. So in 2014, in May, we actually started a preconception clinic. And this was for HIV-affected couples who had expressed fertility desire. And being in a resource-limited setting, there were very few interventions. We had limited interventions that we're able to offer. Some of the interventions we are offering to these couples are PrEP, sperm wash, as Shannon had talked about, the timed and protected intercourse, the home insemination, and for us also for the uninfected male partner, we're also talking about male circumcision as part of an prevention intervention. Some of the challenges we've had are in terms of policy. Pre-exposure prophylaxis is not yet part of, has not yet been included in the national ART guidelines. So we have these couples who have the desire, and we're offering them PrEP, but they have to actually buy the PrEP. And this is actually, it's actually expensive in terms of cost. So we had to limit PrEP for conception planning and sperm wash. So these are some of the services we're actually referring to our policymakers that there's a need for preconception planning, and we need to make some of these services available to some of these couples. So far, we've had, for us, we've had very many discordant couples coming into our clinic from all over Nairobi and accessing these services. For us, there's a need in terms of knowledge gap. We need to meet a knowledge gap amongst our clinicians out there, clinicians in the rural setting, who, if they have a if a HIV-affected couple would like to access these services, we need to be able to offer this standard care package to all HIV-affected couples. So as an organization, the Partners Advanced Care and Treatment, we actually came up with a package, a safer conception package, and it's currently being rolled out for training for other clinicians so that we can be able to offer these services to these affected couples, and also for our policymakers to actually include PrEP and services like sperm wash for these couples and provide these services at subsidized cost, because these are some of the challenges. The couples desire these services, but they're unable to access them. So for us, it is currently a work in progress, and it's still ongoing. Yes. Thank you.
Great. Sheila, thank you so much for providing perspective from the ground, where the work is really being done. And thank you for your advocacy. It sounds like there's a lot of work being done to sort of include the needs of people affected by HIV and their reproductive goals around policy making, as well as around training providers and how to provide some of these services in a primary care setting. So that's very inspirational. Thank you. Shannon, tell us a little bit about how this is happening in the United States.
Great. So in the United States, one thing I wanted to point out, and it links back to something Lynn said, is we did a survey of HIV negative women in the U.S. over 4 years. It was 2 years before the FDA approved PrEP, 2 years after. And one of the significant findings from this survey, the survey was about HIV negative women and ways in which they would like to reduce their risk while they tried to have a child, is that all women were willing to take some level of risk to have a baby. And so I think I want to just frame that little piece for us here, that any opportunity that we have a individual or couple sitting in front of us asking the question is a beautiful opportunity. Because nobody needs our permission to go and have a baby. People are doing it all the time. And so really when someone's in front of us and we can do it in a way that's welcoming and supportive of them, we really invite people in. So I would love to say that I would like that to be the framework that we move forward with. What's happening in the U.S.? So I want to tell you about a clinic that I'm really fond of how they're rolling out PrEP and PrEPception, which is based in Houston, Texas. It's run by Dr. Charlene Flash. This is in the Thomas Street Clinic, which is a standalone HIV clinic that's run by the county, where they see 4,000 or 5,000 people living with HIV. It's a large clinic, and they decided to start offering PrEP to partners and to community members through their HIV testing program. So anyone who comes in and is tested for HIV that tests HIV negative, if they meet the criteria for PrEP, they're offered PrEP. They can go to the PrEP clinic. All women who go to the PrEP clinic are then offered the opportunity to meet with the OBGYN if they want to have a child or they're not using birth control. And so what a beautiful way to kind of scoop all people in rather than just waiting for folks who come forward to us. Another way in which this is rolling out in the U.S. is working with men who are living with HIV, asking them about their reproductive health intentions, and then offering services to their female partners. So we've done that for 4 years here in San Francisco, based at Ward 86, and we're now expanding that to Oakland, but there's also real pioneering work being done with men in Miami and also in Minnesota with the Laura Hoyt's group. And so that's another way in which we can look at rolling that out. In the U.S., importantly, we also have several guidelines which support offering PrEP during the periconception period or when you're trying to get pregnant. So both ACOG and the CDC guidelines support that. And I would note that that's an important part of being able to roll out services for couples, is to be able to have these normative guidances to point to. So I can talk some more later, but I don't want to take away from the other people, so I'm going to stop.
Thank you. Let's go to Natasha. Natasha, please tell us about the work you're doing in Johannesburg. Natasha, are you still with us? Okay, maybe there's some internet connectivity issues. Shannon, tell us some more. I know you have. Natasha, are you back? Ooh.
I can chat some more.
It looks like Natasha is muted, maybe.
Oh, yeah.
Natasha?
Nope.
You're here. Shannon, maybe we'll go back to you and come back to Natasha when the connectivity issues.
So another way that the PrEP or Safer Conception has rolled out in the U.S., you know, Yamini, behind you in the office is that poster called Positively Negative, and it's an electronic or a Kindle book that's available that tells the story of two women. One who opted to use time intercourse without a condom to get pregnant or treatment as prevention, and another woman who opted to use PrEP. And so one of the important ways in which we're moving safer conception forward is finding champions, so women and men who are willing to tell their stories and come forward and either be in newspaper articles, chat at support groups, talk to clinicians about their experience, write their blog and put it up on Hive. And so I think that that's a key piece as we look about rolling this forward elsewhere, is you want to create demand both from the provider and from the consumer. And so it's very important for us to support champions of couples who want to and have used the various options as they come forward. And I guess Natasha's still with us, not with us.
Shannon, maybe tell us about maybe Poppy.
Yeah, Poppy is a most amazing woman who, it took her a decade, and I think this is like not unlike many of the couples that we know who are brave to come forward and start asking, even when it was really not acceptable from providers. Oh, is that our friend Natasha?
Have I come back on?
She's back on. Give it to Natasha.
Okay. Sorry.
We hear you, but we don't see you.
Okay, I'm hoping the camera's coming, but maybe I should just... Sorry to interrupt you, Shannon. Can you hear me okay?
Yes, Natasha, we're ready for you to tell us about your work in Johannesburg.
Okay, so thanks. Sorry. Welcome to Johannesburg, where internet connectivity apparently isn't as reliable as I thought. So sorry about that. I'm a HIV clinician, like I said at the beginning, who's been running a safer conception service now for the last 6 months. It's based in a primary healthcare clinic, so it's specifically designed to try and help couples from a low-cost perspective in their local vicinity so that they don't have to travel to a specialist center. And we are already supporting 200 individuals who've enrolled in the clinic since 6 months ago. And that's with the clinic just running 2 days a week because of limited space. So the clinic is looked after by myself, the doctor, and then I have one primary healthcare nurse who I've mentored and trained up so that she also looks after clients. And that's so that we can so that I can see whether it's going to be possible for nurses to provide this service going forward, because in somewhere like South Africa, where there are 6.5 million odd people living with HIV, it's not going to be possible to keep it limited to doctors. So Sister Thuli, who's the nurse I work with, is doing an amazing job and really proving that it will be possible to make this a service that basically trained nurses will be able to provide. So just in terms of the sorts of people that we're getting along at the clinic, of the 200 individuals, 66 of them are coming as couples, but 68 of them are unaccompanied women. And that's because they are in a position, like Angela spoke about, and Lynn and Shannon also mentioned, that they aren't able to disclose safely to their partners. So although we give them a lot of support and we try to provide them with opportunities to come and test as though they've never tested before with their partner, they don't find it possible to do that, either because they're physically at risk or economically at risk if their partner abandons them because of their status. So although we talk a lot about safer conception being for HIV-affected couples, the reality is there's a lot of people who may not enter the service as a couple, and we need to adjust it so that we can look after people where we don't know what the status of the other partner is. So 44% of those women who are coming on their own have no idea what the status of their partner is, And that means that the choices we offer them are a bit more complicated because we don't know who's at risk of transmitting to who, and we don't know if there are STIs in the picture. So I think for me that's part of broadening out the scope of preconception services to make sure that everyone gets the right to access them and that it doesn't have to be a mutually disclosed couple. And like Angela mentioned, that's one of the issues around criminalization, is that how a healthcare provider is going to be able to look after these women if they know that they're supposed to be disclosing because that's the law in that country. In South Africa, theoretically, it's criminalized because there has been someone who has had a successful law case, but fortunately it's not written into law per se, so we have a little bit of leeway so far. And then in terms of practical uptake, I think one of my biggest challenges is that actually almost half of the people who are coming to the clinic are in known concordant couples. And in some ways that actually frustrates me a little bit because, like we've been talking about, they just need ARVs and to be virally suppressed and not to have STIs. So their prevention, there isn't really HIV prevention in the mix there, apart from in terms of the mum not transmitting down to baby. But they fill up a clinic where there's limited capacity for us to see other types of couples. And I would certainly never ever turn them away because I think it's very important for positive women to be able to access care pre-pregnancy and make sure that their management is optimized. But it means that we're not accessing those at highest risk, which are the discordant couples. And we particularly have very few HIV-negative women coming in with male-positive partners. And for me, that's a concern because in South Africa, about 4% of women seroconvert during pregnancy. So they start their pregnancy HIV-negative and they become positive during the pregnancy. And they're the ones where we're seeing the transmission happening down to baby. So if I can't engage those women in preconception care, I can't help them to stay negative during their attempts to get pregnant safely. So there's quite a lot of questions in my head around how we market these services to reach out to the right people. So in total, we've had 11 pregnancies, which is great, but it's been a slow process. And one of the reasons for that is that a large number of the people attending have possible subfertility. And as others mentioned, we don't have access to assisted reproductive technologies in South Africa. So if I come across a couple who it looks like they have a fertility issue, there's not much I can do to help them, apart from to make sure they're getting their timing right and that their health is as good as possible. And then if they aren't pregnant within 6 to 9 months of trying, I basically encourage them to continue at home, but not to take up space in my clinic so that I can get other people into the clinic. And that seems harsh. So I find that quite difficult. And just in terms of PrEP, we have just been licensed in South Africa last week. So that's a great step forward for us. But in terms of our clinic, we haven't had anyone choose to buy PrEP for their own sake yet, because it was something they had to buy. So I think that might shift once PrEP policy is released and people will be able to access it free at their government clinics. So I'm sorry, because I'm not on video, I hope you're all managing to follow what I'm saying and that you can hear me okay. So just, I think in terms of learning points going forward, Lynn's interest is particularly in men, and what we're struggling to do is engage the men. And 26% of our females have an unknown status partner. So we are not managing to get them to come in and test and access treatment if they need to. And we're doing quite a lot of thinking about how we might be able to shift that to encourage men to come through. My other big challenge is that, Lynn spoke about maybe we don't need condoms for HIV prevention, but we do need them for STI prevention. And STI rates are very high in South Africa, but we are limited to only syndromic screening, which means asking some key questions and then doing a clinical examination. I can't send any laboratory tests to pick up STI. and yet we know STIs are often asymptomatic, and we know that STIs can contribute to subfertility or infertility. So then I'm stuck with not knowing whether I can advise people to leave the condoms or not from the HIV side of things, but from the other STIs. And in fact, one of our adverse events has been one lady who was admitted for pelvic inflammatory disease after we gave her advice on timed conception, because presumably there was an asymptomatic STI sitting in that partnership, which then presented. So there are quite a lot of practical things that make what initially seems quite simple more complicated when it comes down to actually providing the service in a real setting. And yeah, I don't know how I'm doing for time, but just the other thing is it takes time. These clients have very complicated relationships, and they have complicated histories, and they often have had multiple child losses or pregnancy losses in the past, and so there's a lot to talk about. And if you're talking about 6 million people who might possibly want to access the service, then it's going to be difficult to provide the level of counseling which I'm finding many couples require in order to be able to be well looked after. So yeah, I think that's pretty much the reality of a safer conception clinic in South Africa.
Great. Natasha, thank you for complicating the conversation for us a little bit, just around sort of mutual disclosure. That's not always the case. Also, thank you for opening up your practice to the couples that are in concordant relationships and also continuing to provide them counseling. Thank you for the work that you're doing on the ground. And Sheila, especially thank you to you also for doing the work on the ground in Nairobi. We are pretty much out of time, and we have one question that was asked, and it's about same-sex male couples hoping to use a surrogate. And so I wanted, because it's sort of a US-based question, for Shannon to answer this. Shannon, the question is, how have you been advising or working with HIV-positive male couples who are hoping to use a surrogate? We have had issues with providers feeling comfortable with surrogacy in general, as well as issues with CDC guidelines around this.
Yeah, great question. There's actually a ban by the FDA in the U.S. to use the sperm from someone who has anal sex for assisted reproductive technology. So there's much homophobia embedded in our practices to begin with, HIV aside. Yamini led the creation of an important tool for same-sex couples living with HIV that's on our website. And I would really encourage folks to go there because we link to some important tools. And there are legal implications related to the parenting arrangements, regardless of where you live, so it's questions that are worth asking. That being said, we've worked with couples who've worked with the surrogacy program in Southern California, as also in addition to couples who do what's called co-parenting. So it's less of a formal surrogacy relationship, but a non-intimate partnership in which they agree to have and raise this child together. And so I know we're short on time, so I'll say go to the tool, give us feedback. We only want to make it better, and I look forward to hearing more from couples who choose this important route. I would like to say I think every child should be that lucky to be so wanted and so planned for. It's really a beautiful thing.
Thank you, Shannon. And yes, definitely visit our website, HIVEonline.org, and there's tons of materials that have to do with everything that was talked about today. There are videos with almost everyone that's on this Hangout today, and so you can see them in a different form talking about somewhat a different thing. Overall, I just want to say thank you, Angela, thank you, Lynn, thank you, Natasha, thank you, Shannon, thank you, Sheila. I hope to hang out with you again on air again sometime soon and hear more about the work that you're doing. For today, that'll be it. At the end of this broadcast, there will be a slide with lots of different resources that you will be able to click on eventually and go right to where they are coming from. And that's it. Thank you all, and have a wonderful day ahead.
Thank you, Yamini.
Thank you.
Bye.
Bye.
Thank you.
Thank you.
Bye.